Audio recording for this meeting has begun.
Good afternoon, and thanks so much for joining. This is Hannah Wicki. I am the Communications and Provider Services Manager for the Wyoming Primary Care Association. To allow time for plenty of Q&A, I'm going to have Bobby introduce herself. Just a quick couple of things. We'll be having a Q&A session at the end. If you could please chat or type your questions into the chat box. We will address them at the end of the session. And also, evaluation will be sent out via email, so please fill that out, and that will also provide an opportunity to ask additional questions if we're not able to address them here today. So with that, I'll let Bobby introduce herself.
Thank you, Hannah. I am Bobby Nielsen. I am with Institute for Community Alliances. I am the program manager for the state of Wyoming. Institute for Community Alliances covers 11 different states across the country, and we focus on homeless management information, which is HMIS, and the tool we use is Service Point, so some of you may be familiar with that. But also what we do is work with continuums of care, and one of the things we do is help with coordinated entry, which is why we're doing this webinar today, to introduce you to coordinated entry, what it involves, and how Wyoming is currently doing that process. So we have, I need the mouse. Oh, sorry. That's okay. We're going to move forward with this. And again, as Hannah said, if you have questions at any point during this presentation, please put it into the chat. All of you are muted, so you're not going to be able to verbally ask questions at this point in time. This first screen talks about the HUD brief that outlines coordinated entry, and it's a very formal process, but basically it helps local providers design a system that is unique to them. So for Wyoming, we can create a coordinated entry system based on our current services that we provide and then the strengths of our services. So our coordinated entry may not be exactly like anyone else's, and that's very, very appropriate because HUD allows us the flexibility to design a system that works best for our area. Whoops, I apologize. So we use a standardized assessment to do coordinated entry. We use what is called the VI-SPDAT, which I will talk about a little bit further in the presentation. But this allows us to assess everyone individually, but also in the same manner. So it also allows us to provide the best choices for client housing. And if there's more than one choice, they be able to choose what housing option they feel is best for them. We also want to focus on interventions for the people with the highest need. So we do prioritize clients, and we do that in a very specific process that I will talk about in a few minutes also. The process to coordinated entry is so that many agencies are working with clients, know when there are housing options available. Oftentimes what happens with case managers, they know what might be available in their own communities, but in a broader sense, this allows us to open up the housing opportunities for clients across the entire state. So if a client is willing to move to another area, they possibly could get housed faster. This talks about the crisis system and how it is different than just the homeless system. So crisis system looks at the larger picture of clients and what they need versus just who a case manager happens to know about because they showed up at that agency's door. So it really broadens the case manager's view of the service delivery system and enables them to then give their clients a broader sense of solutions. This is a comparison between project-centric process of delivering services and a person-centric process of delivering services. So traditionally, we've been in the project-centric. So we serve whoever shows up at our door. We serve whoever applied for our projects first. So it's not necessarily based on need, but timing. And that requires that the clients be lucky enough to show up at the right time when there's a housing option available. With person-centric, we're looking at who has the highest need, and we do that by assessing them with a standard assessment tool, which we use the VI SPDAT, and then coordinating throughout a whole larger geographic area to provide possible solutions for clients versus just a very small geographic area. With person-centric, we also more involved the client in that they have choices. They may not choose to go into a housing project that is available right now, and that's okay. That is their choice. And so they remain on the priority list until another housing option comes open. So it really does involve the person versus fitting the project requirements, which is a big change in our homeless industry. We have some core elements to coordinated entry. One is that standardized assessment process, which we use the VI SPDAT. VI SPDAT was created by OrgCode out of Canada. It is the triage tool that is most commonly used across the country and in several other countries. What it is a tool that assesses the client's needs right at this moment. So it's not unlike going to an emergency room, and if I arrive with a sprained wrist and I'm waiting, but someone comes in after me that might be suffering a heart attack, the triage process is going to be they're going to serve the person with the possible life-threatening condition versus a sprained wrist. So we want to do that, move towards that with our coordinated entry process, in that we want to prioritize the individuals with the highest need. Who is the most likely maybe to die on the streets if they don't get housing? Who's suffering the most trauma? Who's been homeless the longest? So the VI SPDAT is that triage tool that we use. There are 3 different VI SPDATs. There's one for individuals, so people by themselves. There's one for families that takes into account, do you have young children? Do the older children have to take care of the younger children so the parents can work? So it has questions specific to families. And then we have a youth VI SPDAT, and that is specific to unaccompanied youth under the age of 18 and the special circumstances that are often occurring with them being homeless. So right now, Wyoming is using the individual and the family VI SPDAT. We are hoping to move towards using the youth VI SPDAT in the near future, but right now we are just using the individual and the family. One of the populations that Wyoming has chosen to focus on is anyone or family that is determined to be chronically homeless. This is a specific definition based on some criteria. The individual has to be 18 years or older, or a family with a member who is 18 years or older. So that could be a child that is 18, or it could be one of the adults, one of the parents. They also have to have a disabling condition. So they have to have some type of condition that affects their lifestyle. They also have to be homeless at least 12 months consecutively or continuously, or had housing, been homeless, 4 or more times in the past 3 years. So it's a little bit of a convoluted definition, but what we have found is people or families who fall into this criteria typically have the highest level of needs, where housing and stability of housing could help improve their lifestyle and quality of life. So we have focused on people who fit that definition, or families who fit that definition, and typically they can go into what we call permanent supportive housing, which is long-term housing. There is no end date to that housing. They can live there indefinitely, but they have to fit this chronic homeless definition in order to get into that housing. So permanent supportive housing is one of our levels of housing. We also have what we call rapid rehousing, which is shorter term assistance. You don't have to have a disability or be considered chronic to qualify for rapid rehousing. And that assistance is basically getting somebody through maybe a temporary situation where they're homeless, and with a limited amount of assistance can get back on their feet and be fine. Then we also have transitional housing, which people in transitional housing can stay 18 to 24 months and typically need more assistance than what rapid rehousing could offer. So for all of those levels of housing, permanent supportive, rapid rehousing, and transitional housing, we prioritize chronically homeless people who fit that definition. So we're going to serve them first, no matter what level of housing that they need or want, because the client has a choice. If they technically fit the definition for entering permanent supportive housing but don't want to, then we can look at doing rapid rehousing for them. It's the client's choice, which that means we're moving to that person-centric model of services versus the project-centric. If there are no persons available or that we're aware of that fit that chronic homeless, then we move to the families or individuals who are non-chronic. So again, that's part of that priority where we just still look at the people who have the highest need, and when the very highest need, we're not aware of them, we go to the next highest need. And so part of that is how long they've been homeless and how many times they've been homeless. So this just outlines the non-chronic homeless prioritization. Also, there's different ways of implementing coordinated entry. We have adopted what is called the no wrong door. There's also where you can set up centers where people have to go to a specific place to be part of the coordinated entry. Due to the vastness of Wyoming, as we all know, the no wrong door allows us to assess clients wherever they present for services. That could be at emergency shelters. It could be at any agency that provides assistance for housing. Could be any agency that specifically provides services for veterans. They're going to be assessed in the same manner, and determined need is going to be done in the same manner. Wherever they present, the client can do a VI SPDAT. It's about a 10-minute assessment, so it's not very long. And then they're referred to what we call a priority list. We have a list for veterans, and we have a list for what we call non-veterans. So from those lists, the housing agencies in the state that provide housing go to those lists, see who is determined to have the highest need, and those people are offered that housing option first. Case management goes along with that. Case management is offered through the agencies that participate in coordinated entry, and that's just to help ensure that we are offering clients the appropriate housing opportunity, and then also working with them once they're in that housing in order to ensure that they can sustain that housing opportunity, because we don't want to put them in housing and then have them turn around and be homeless again in the near future. That's not our goal. We want permanent housing for a long period. This is a visual of how clients flow through coordinated entry. So we start out with a client presents at a project that does coordinated entry and can get that VI SPDAT completed. With the VI SPDAT, we don't VI SPDAT every person who presents at like an emergency shelter, because statistically we know if clients that present at a shelter who have minimal needs, they just need resources, they might need some temporary help, can resolve their homelessness on their own. So we don't do a VI SPDAT on every person. We basically screen them to see who can't resolve that on their own. And so we do a VI SPDAT. Once that is completed, we send them over through Service Point, which is a tool. We send them to the Wyoming priority list. And that's that list where we then assess who has the highest need and what is the next housing opening. From that list, we have case management meetings on a weekly basis, and we go through those lists. We case manage every client's name that's on the list. We determine, are they still in need of housing? What's going on? Have they maybe left the area? What are some special needs that they might have? And so we case manage those lists on a weekly basis. Once we're aware of a housing option that's open, a referral is sent to that agency so that they can assess that client. Does the client want that to go into that project? Do they fit the criteria for that project? And that type of thing. If everything is a go, the client enters that project and moves into housing. Then it's up to that particular project to ensure some case management so that they can sustain that. If the client doesn't want to go into that project, or they don't quite fit the criteria because of funding requirements or something, the client then remains on the priority list. So when the next housing option becomes available, they are off, and they're still at the top of the need priority, they are offered the next housing option. So it's not a one-time shot and you're done, because not every project fits every client. So we want to make sure that we are on an ongoing basis working with clients to find the housing opportunity that best fits them. So it's not a one-shot deal. The clients have the choice to remain on the priority list until the next housing option comes along. So we know some statistics. Wyoming has been doing coordinated entry for about a year. We actually started 10/1 of 2007 or 16. So from that, we know that right now we have 11 people on our priority list who fit that chronic homeless definition. So they are the clients that we are focusing on first. They're going to be the ones that we really look for housing opportunities. The other thing to note is when someone's on a priority list, the case managers don't stop looking for housing for them. They continue to find housing wherever they can for these clients, as long as it's something that they can maintain. So they can be on the list but move into their own place. They could maybe move in with family or friends, and as long as it looks like it's going to be a permanent situation, we take them off the priority list. We don't wait for an agency to have an opening because we have limited resources within our agencies for openings. So right now, 11 are chronically homeless. We have a total of 49 people on the list as of right now. So that was of Monday, the 26th. In that time frame of 10/1/2016 until the 26th of 18, we had 181 people housed from our priority list. Now that they've gone to some type of permanent situation. 42 of those 181 have gone into housing projects. So there's a number of housing projects throughout the state, and they've moved into those projects. Now that's a relatively low number compared to our 181, but that's based on if it's permanent supportive housing, there may not be a lot of openings at any given time because people can stay indefinitely. So this really does represent a good number, even though it's a fraction of the 181. We know that the average VI SPDAT score for individuals is 7.8 out of 20. So the highest points is 20. So they're scoring not quite halfway, but what we do is we look at whatever score they have in this range of that. That might be the average, but we'll have people that are scoring 13 and 15, and again, those are the people that we would consider looking at first for housing. For our families, they're scoring a little bit higher. We don't have as many families on our list. I think currently we have 3 families, and so because there's less families that we have assessed, their average is going to be a little bit higher. Average length of days on the priority list is 80. So once someone is put on a list, they average about 80 days before we take them off for whatever reason. It may be they disappeared, we're not in contact with them anymore, or whatever the reason. But for the people who have obtained housing, they stay on an average of 78 days. Now, HUD has put out the standard that when someone goes on a priority list, they would like to see them housed within 60 days, which is a very short turnaround. So we're not very high above the HUD standard, but again, that is based on our local resources. So we can't necessarily hit those 60 days, but we're pretty close. So we feel we're doing a really good job with getting people housed and focusing on that permanent housing with people. So I have a couple stories. Let me move my notes forward here of what's been going on with coordinated entry. So one of our agencies in Gillette, Community of Community Services, realized that in their community they had a need for families who needed permanent supportive housing, but also needed reunification with their children. So they've been in a situation where the children have been removed. They're working with Department of Family Services to reunify the family. But one of the criteria is they have to have housing. And if housing is a struggle for the family, Council on Community Services designed a permanent supportive housing project specifically for those families. So in order to enter that project, a client needs to be in the reunification process. This is unique. I've never heard of a project that specified that criteria before, but they've had huge success in that. They opened up last year, and I believe it's 3 or 4 families that they have already moved into that project and had reunification happen. So once the children are back in their home, they also get to continue to stay in that housing project should they choose to. So it's not temporary, it can be permanent, which helps create that stability for the family while they're transitioning with the children back in the home. That's a huge success for people because without that housing, those families may not have ever been reunited. We also had a gentleman that was working with Community Action Partnership of Natrona County in Casper, who does a lot of street outreach. He'd been on the street for several years and chosen not to participate in the process for obtaining housing, which for some projects and government entities like the VA, it can be a little convoluted and overwhelming to apply for some of those benefits. So he had chosen just not to participate. But through the street outreach effort of the staff from the Community Action, they helped him through that process. They got him benefits, and he's now living here in Cheyenne in permanent housing. So we had a person who had been on the streets for a long time and was probably at risk of eventually dying on the streets that is now housed permanently. That's a huge success. It might be only one person, but there are multiple stories within our coordinated entry process that exemplifies the work that these case managers are doing and how they really emphasize finding housing for people and not accepting the fact that someone's living on the streets and that's okay. So coordinated entry, while it's a process, really is dependent on our case managers. So what's next for Wyoming? We'd like to expand coordinated entry. Right now we are only using, or the partners that are participating are funded through Emergency Solutions Grant funds or Continuum of Care funds. So that's a pretty limited pool of providers. So we would like to expand that to health service clinics, housing authorities. Landlords can participate if they have openings and are willing to work with agencies, guaranteeing that part or all of the rent will be paid. They are integral to this process. Non-federally funded agencies who are not required to do this process, and then faith-based agencies. But specifically, I'd like to focus on the health services for the homeless, which is you guys. I wanted to shout out to the Community Connections through Sheridan Public Health Department. They started a project, I want to say early last year, and what they are doing is they're an information and referral process for the people in Sheridan. Unfortunately, the local emergency shelter in Sheridan had to shut down, so they were very worried about what were people going to do that had utilized the shelter. So they have started using ServicePoint, which is the HMIS tool for Wyoming, and they're an information and referral process. So when they become aware of a client, they can direct the client where to go for assistance, and then they do outreach. So they're really looking for the people who maybe are living on the streets and connecting them with local entities, whether it's faith-based, nonprofit, or projects or agencies who can help with obtaining that housing. Then they also provide short-term case management. So they follow up with clients that they've had contact with. Were they able to obtain the services through the resources that they referred them to? Is there any other needs they have? And they also focus on the medical needs for these clients, because we know that people who are homeless and in crisis, one of the things or places that they may go first before anything else is health services, especially families who have children. They're going to reach out for health for their children. So the health clinics that serve the homeless could easily be a front door or no wrong door for coordinated entry, because you guys may have access to those people who need additional services, but the other services are not aware of them. Or it may be overwhelming for the client to try and obtain those other services. So Sheridan has done, Community Connections in Sheridan has done an amazing job in connecting their local residents to local resources and helped people obtain housing. So Deborah Haar, and I apologize that I don't have her contact information up here, but she is with Sheridan Public Health Department. She indicated she would be free to answer questions if you have questions about how they've been doing that or how they got started. So a great resource. So please contact Deborah Haar with any additional questions. Continuing on with what's next for Wyoming, we want to increase our rapid rehousing and transitional housing options. We also want to create priority lists for them. Currently, we are only prioritizing permanent supportive housing, except for veterans. We do have a rapid rehousing priority list that is specific to veterans. So the Cheyenne VA is looking at their VASH vouchers for them, but then also Volunteers of America utilize that list for their rapid rehousing. But there are non-veterans who need rapid rehousing and transitional housing, so we want to expand our coordinated entry to include that population. We want to increase the length of time for case management. We want case managers to be able to spend a longer time with clients. So instead of 1 or 2 case management visits, maybe it's up to 6 months. Whatever it takes to stabilize that individual or family and keep them in permanent housing is what our goal is. So we want to we want to base our assistance on need and not necessarily time. That's a big change because typically it's been, well, you can get X amount of time of assistance, and we want to change that based on need. Prevention and diversion. Unfortunately, we will never stop or end homelessness as long as people cannot stay in their current residences. So one of the things that we want to do is expand prevention and diversion, and then also prioritize who are we going to assist first, who needs it the most with prevention and diversion dollars. So this would include paying to stop evictions, keeping or turning back on utilities, catching someone up on their rent, things like that that would keep people from becoming homeless and having to access the homeless system. Once someone is in an emergency shelter and in that cycle of homelessness, it takes a whole lot more dollars to end their homelessness than it does to prevent their homelessness. Unfortunately, it's hard to know who needs it the most when it comes to prevention and diversion, so that is something that we're looking at. We want to use our dollars in the best way possible because they are limited, but it is something we need to definitely look at in Wyoming. And then again, increase that length of case management. So if we have caught someone up on their rent, they were 2 months behind, we've stopped any eviction process, we want to increase the case management contact so they're not in that situation again, so that we can, is it teaching some budgeting skills? Is it just prioritizing how they're spending their money and things like that? And that's only can be done through case management. So we want to increase the length of case management for diversion and prevention also. Whoops, I'm sorry. So specifically to this audience, what can you do? Well, there's several things, and the top of the list is participating in HMIS, so using Service Point for a certain population of the clients that you see. You're a health clinic, so not every client that walks in your door would be appropriate to use an HMIS. It's the ones with the highest need that are homeless that we would want to focus on. Complete VI SPDATs on clients. Again, it's like a 10-minute triage tool, so it doesn't take a long time to do. And then referring to the priority list. Participating in that also helps if you participate in the weekly case management meetings. Those are done on Monday mornings every week, and we go through those lists and we just assess where the client's at. Have they moved from city to city? Are they still in need of housing? Have they obtained housing since the last meeting? And things like that. But you guys in the clinics could really help us know, is someone living on the streets? Are they showing up at your clinic and nowhere else? And so really knowing where those clients are helps us in obtaining housing for them. So that's the main way that you could be involved in coordinated entry. That's the end of my presentation, but I wanted to just source where I've gotten some of my information. HUD has a strategic plan to end homelessness. It's called Opening Doors. You can find that on the HUD website. There's also a coordinated entry policy brief, and this outlines the broad outlines of how to do a coordinated entry or coordinated assessment system. It is in the Continuum of Care Program Interim Rule, so I have cited where you can find that should you want to. And then also the Homeless Management Information System that Wyoming uses called Service Point. We are now ready, I think, to address some questions. So here is my contact information. So we also wanted to put this up in case we don't get to your question or you think of a question later or you want to contact me. Here is how you can contact me.
Okay. Great. Well, first off, I want to point out that Deborah has provided her email in the chat box if you would like to contact her and follow up with what they're doing. But our first question, and there's still plenty of time for you to submit yours, please use the chat box to do so. So where are there resources online about the 3 different types of VISPEDAT assessments?
You can go to orgcode, orgcode.com, and the VI SPDATs are actually a tool that they have provided for free for communities. There's a training you can go through the OrgCode website on how to administer the VI SPDATs. So orgcode.com, O-R-G-C-O-D-E.
All right. And then where is the definition for chronic homelessness cited from?
That is cited from the COC interim rule, so you would find it in this policy brief. It is, what I presented was a portion of that definition. It is really outlined in this interim rule.
Great. Well, that's all the questions that have been submitted through the chat box so far. Still have time if you want to submit a question. But in the meantime, this webinar will be recorded and available on our website for future reference. I'll wait a little bit longer to see if anyone wants to submit a question, and then we'll probably call it a day.
Okay. Please, if you have questions, put them in the chat box. We'd love to address them.
Oh, there we go.
Good. Thank you.
Okay, so we'll be making the recording available online, and then did you want to share just
We can share the slides too. That's fine. Yes.
So we'll be posting it on the Wyoming Primary Care Association website, so that's wypca.org. So just keep a lookout there. It's on our resources page. We have a specific area for webinars, and it'll be featured in that section. Well, it looks like you were very thorough and nobody has any questions. So thank you, everybody, for joining today. We'll again watch out for that evaluation. We would love to hear your thoughts. And then if you feel more comfortable submitting your question that way, there is a section where you can do that. Oh, I guess we got one more. Okay, thank you, Valerie.
Thank you, Valerie.
All right, thank you, everyone. Have a great day.